So how do I read a Kaplan Meier curve, and what is a hazard ratio? In this tutorial, you are going to learn about both.
Welcome. This is Eric McCoy, aka McCoy, aka EMAC, from the University of California, Irvine Department of Emergency Medicine. And in this tutorial, we're going to talk about understanding the Kaplan Meier curve. By the time you are done with this tutorial, you are going to be able to describe the components of the Kaplan Meier curve, discuss the type of analysis that the Kaplan Meier curve allows, and last but not least, you're going to be able to compare the Kaplan Meier estimates between different groups. Outcomes in medical literature.
So outcomes in research are vitally important. Outcomes drive individual patient decisions as well as patient population decisions. And it's not just outcomes, it's differences in outcomes between patients who may have a different therapy, a different treatment, or even different risk factors. For instance, in the cardiology literature, we may be interested in looking at the differences in mortality behind patients with a heart attack who either receive a stent in one of the coronary arteries or a coronary artery bypass graft. How about in the neurological literature? We may be interested in 30-day mortality or 30-day functional neurological status in those patients suffering an acute ischemic stroke who get endovascular thrombectomy plus standard care or standard care alone. How about in the pulmonology literature? You may be interested in the rate of intubation in those patients with a COPD or CHF exacerbation who either get A, non-invasive positive pressure ventilation, or B, standard therapy alone. How about gastroenterology? You may be interested in differences in mortality rates between your patients who are alcoholic cirrhotics who have a GI bleed, who either get A, antibiotics, or B, no antibiotics during their hospital admission. What about OB gynecology? You may be looking at the differences in rates of cone heads behind the babies that you deliver either with that suction device or via C-section. So outcomes in the medical literature drive just about all of our medical decisions. But for some outcomes, healthcare providers, researchers, investigators, and well-informed consumers of the medical literature may not only be interested in whether or not the outcome occurs, but the time to that outcome or the time to that event. And in healthcare or in medicine, that's called time to event analysis. For instance, in the oncology literature, you may be interested in the average duration or average lifespan after taking treatment A versus treatment B. What about if you're an orthopedic surgeon? You may be interested in the duration of time it will take you to either repair or replace a hip prosthesis A versus hip prosthesis B. So how do we evaluate time to events? Well, for the most part of the medical literature that you're going to read is called time to event analysis using Kaplan Meier analysis, which use Kaplan Meier curves. So we're going to do an example where we're going to break down the components of a Kaplan Meier curve.
So in this example, we're going to take a look at the components of the Kaplan Meier curve. And let's start off with the axes. On the y-axis is the survival for survival analysis, but it could be any event. And this is 0% survival all the way up to 100% survival. And on the x-axis is time, typically in days, months, or years. And in our example, our axis is in years. So in our example, we're going to have, in patients with a history of pancreatic cancer, does a new drug, drug A, decrease in mortality or increase the survival compared to an old drug B? Let's take a look at how this Kaplan Meier curve is constructed. So we see here on our y-axis is survival. So this is 100% survival, and the x-axis is time. So you can see anywhere between 0 and 2 years with regards to drug A, there's 100% survival. But these intervals here are called intervals, and what stops an interval is something called an event. Event of interest in this case is death or mortality, and so anytime an event occurs in any patient, that stops an interval or ends an interval. So in this case, an interval happened or an event happened at 2 years, so this interval has stopped. And if we have a total of 10 patients in our group A, what proportion of patients would you think remain after 1 out of 10 patients have died? You'd be correct, 9 out of 10 or 90%. And so how do we calculate that? Well, how many patients were in this first interval were at risk? Well, if we started off with 10 patients at risk, we have 10 patients at risk. And if one of these 10 patients died and 9 made it to this interval, well, how many survived that interval, which is 9? And so you take that ratio, 9 over 10, and you get 90%, or 0.9 as a proportion. And again, this is an interval here. And what ends interval? Events end intervals. And so this interval here only goes for 1 year, from 2 to 3 years. And since we had an event occur that ends this interval and it starts another interval. And if we have here 1 patient of these 9 who have died and 8 have made it, we have an 80% survival rate. So let's calculate that. Let's go through these computations. How many survived, or how many were at risk, in the previous interval? There were 9 total at risk. And how many survived to make it to the next interval? So of these 9 patients who were at risk in the previous interval, and an event ended the interval, that means how many made it from this interval to the next one? Correct, 8. And so how do we calculate this probability in this interval? Is 80%. And so how did we get that? So this 0.8 as a proportion, or 80 as a percent, is called the cumulative probability. In fact, all of these intervals represent the cumulative probability of survival at any particular point in time in the study. And how we got this 0.8 or 80% cumulative probability is we multiplied the probability that any particular patient survived to the previous interval and made it to the current interval. And so they survived to the previous and made it to the current interval. So what's the probability that a patient made it to the previous interval? Well, that's simply the cumulative probability of making it to that interval, which is 90% or 0.9, and made it to the next interval, which is 8 over 9. Of those 9 that were at risk, 8 made it. 0.9 times 8 over 9 is 80%. And this 8 over 9 here is called the interval probability. Now, if we were to take a look at our first computation, it's the same thing. If we had a total of 10 patients here were at risk and 9 made it, this is the interval probability, and the cumulative probability here was 100%. Why? Because 100% of patients were alive in this first interval, which is where we got the 1. Let's continue. The next interval, okay, 70%. How do we get that? Total of 8 patients were at risk in the previous interval, and an event ended the interval. So of these 8, how many made it to the next interval? Correct, 7 made it to this next interval. And if we were to calculate our new cumulative probability for survival for this interval, it would be the probability of surviving or getting to the previous interval, which is 0.8, times the probability of making it to the current interval, which we get 0.7. But in this interval, something happened. During this time in this interval, a patient was censored, which is typically indicated by a tick mark here on the interval. And what censoring means is that something aside from the patient suffering the event of interest occurred. That could have been the patient was lost to follow-up, the patient didn't want to participate in the study anymore, the patient moved to a different country. Something happened aside from an event, but we no longer have patient data to track. And so that's called censoring. So 2 things can happen to a patient at the end of this is called serial time. So at the end of their serial time, or their clinical course duration time, we could either A, follow them until an event occurs, or B, follow them until somehow we lose them to follow-up. And this is what this censoring means. So this indicates that 1 patient was censored during this interval. And that has an impact and influence on our estimates of effect. Because if we were, like we did in typical studies, if we're only interested in whether or not the event occurred, and we wanted to look at the data 10 years after, well, we'd come to the conundrum. Well, we had this patient who was with us for 5 years, and we lost their data at the 5th year. What do? Do we throw all their data away? Or an alternative is we can use their data for as long as we have their data. If you see, in all 5 of these years that we had the patient data, it was able to contribute to our estimates of survival. But up until this point, that patient's data can no longer contribute to our estimates, and after this point, our estimates become less precise because we don't have all of the patient data. And so let's take a look at the implications for censored patients with regard to what happens to our cumulative probabilities thereafter. So this next cumulative probability, you may have guessed, would have been 0.6 or 60%, but wait a minute, it's a little bit lower than that. How did we get that? Well, remember, there are implications for patients being censored. How many were at risk in this interval? Well, initially you might think 7, but not so much. If one patient was censored, meaning we don't have their data anymore, well, we can't necessarily include them in the at-risk group. And so since we lost one patient to follow-up or they were censored, instead of 7 patients being at risk, now we have 6 patients being at risk. And of the 6 patients being at risk, how many of those patients made it to the next interval? Well, if an event occurs and that ends an interval, well, of those 6, how many made it to this interval? Correct. 5 out of the 6 patients. So how do we calculate the new cumulative probability? The probability of surviving to the last interval, which is 0.7, times the interval probability, 5 over 6, and we get 0.58 or 58%. Now, you may be questioning, well, why did we have to remove that patient from the number at risk? Well, if we were to include all the censored patients in our subsequent calculations and assumed that they didn't die, we would be overestimating patient survival. Conversely, if we assumed that we kept all the censored patients in and assumed that they all died, we would be underestimating the ultimate probability of survival. And so between those extremes is where the true cumulative probability lies. And so that's one of the benefits of using Kaplan Meier analysis, is that you can have a relatively accurate estimate of the cumulative probability for as long as you have the patient data. And the more patient data you lose, the less accurate your estimates become. So let's take a look at this next interval. And I think you're getting the hang of this. So how many were at risk there? 5 were total at risk. And of those 5, how many made it to the next interval if an event is one patient suffering mortality? Correct, that's 4. And so that cumulative probability is 47%. And again, we're going to do this with the next interval here. 4 patients were at risk, and of those 4, how many survived? 3 out of the 4. And how do we calculate that cumulative probability? You've gotten this by now. It's 35%. And at the end of the 10 years, or the end of the data collection, these patients here are censored, meaning that at the end of our collection of the patient data, we can't say they all died. We don't know what happened after the 10-year mark. And if you didn't do your study into perpetuity, all these patients here are censored, so we can't make any estimations or guesstimations about what happened to these patients because we don't know. These patients could have died 10 years and 1 day later, or 70 years later. We don't know that. And again, these are estimates of survival. And you might be saying, yeah, wow, this looks like a staircase. And in EMAC, all the Kaplan Meier curves I've ever seen, if you've seen some this far, they don't look like stair steps. They kind of look like squiggly lines. And in fact, you'd be correct. So in general, what happens with these Kaplan Meier estimates is these vertical lines are placed, and these vertical lines are placed simply for aesthetic purposes. So when we're looking at a line, it looks more pleasing to the eye. And you don't typically see all these computations in Kaplan Meier curves. What you see is this. And so when you're looking at a Kaplan Meier estimate or survival estimate for a particular group, you're essentially looking at a line that shows you what their cumulative probability of survival is at any particular point in time. Now, this blue line happened to correspond to the patients in group A or taking the new drug, but the same thing can be done for patients taking the old drug. And so if you make your Kaplan Meier estimates or your Kaplan Meier curve, and if we were to do those computations, for those of you who really want to do the computations, feel free to pause the tutorial now, but otherwise, you can take my word for it. But this is what we would get when you have Kaplan Meier estimates of 2 groups. The blue group here happens to be the intervention group or the new drug group. In this group here happens to be the old drug group or the control. In this case, it's called an active control because this control group is indeed getting a therapy. And when we're looking at these things, there's many things we could compare between these two groups with regards to their estimates or their survival estimates. And one of them that you're going to see in the medical literature is something called median survival. And essentially what median survival is, well, at what time do the 50th percentile or 50% of the patients remain? Or conversely, at what point in time have 50% of the patients suffered the event? In this case, it's mortality. So at what time have 50% of the patients died? And if we were to look at the median survival in group A, how do you do that? Well, 50%. This is the median or the 50th percentile. You go all the way across until you hit that Kaplan Meier curve, and then you go down to the x-axis, and that gives us a median survival of 7 years for the patients in the new drug group. But how about what's the median survival for the control group, in this case an active control? So median, or the 50th percentile, you go here, 50%, and you go all the way across until you hit their Kaplan Meier curve. Once you hit the curve, you go down to the years, and that's 4 years. And so this is one of the ways that healthcare providers, researchers, investigators, or well-informed consumers of the medical literature compare two different groups or two different Kaplan Meier estimates between either treatment and control, which could be placebo or can be an active control. But you can also say, well, what is the 5-year survival of these patients? In that case, what you want to do, or 7-year survival, or 10-year survival. And so what you do in those cases is you look at the year of interest. For instance, if you want to look at the 1-year survival between these two groups, well, the 1-year survival go all the way up to these groups. In the intervention group is 100%. But what's the 1-year survival in the control group? You go all the way up until you hit their Kaplan Meier curve. It's 90%. So you can also ask the question, at what point in time, at how many years out, what's their survival? What's their 3-year survival? If we go to the 3 years, you go all the way up. It's somewhere between 50 and 60% in the control group. And if you keep going up and you hit the intervention group, it's 80%. So there's many different ways that you can look and compare the differences in survival rates between intervention and control. Because one of the main things we as researchers, well-informed consumers of the medical literature, even the lay public want to know when they're looking at these things is there a difference between the survival between these two groups? And in general, you would think you could do it with just looking at the picture, but there's going to be some things you also need to know we're going to talk about. But for right now, I want you to think about this right here. You may have in your past, or you may not have in your past, rode on some water slides at a water slide park. And you remember the first time you got on one of the really steep slides at the water slide park, because most of them, you could sit at the top of the slide and you can look and you can see the contour of the whole slide all the way down. But there are some water slides that are so high that when you get up there, all you see is the edge of the water slide, and you look off and it's almost like you can see the arc of the surface of the earth, like, man, I'm pretty high and this is going to be pretty dangerous. Why were you a little bit more scared with the steep slide compared to the shallow slide? And the reason why you were more scared with the steep slide compared to the shallow slide is because you inherently knew, whether consciously or subconsciously, that the steep slide had an increased risk of morbidity or even mortality with it compared to the shallow slide. There was more risk of danger the steeper the slide got. There was more risk of getting injured the steeper the slide got. And I want you to think about that when you're looking at these Kaplan Meier curves as just food for thought. So imagine here at the upper left-hand corner on your Kaplan Meier curve, this is the top of the water slide. You could either A, ride a relatively shallow water slide, or B, ride a relatively steep water slide. So in general, as you know with the water slides, the steeper the water slide, the more you're concerned about the risk of morbidity and mortality as opposed to a more shallow water slide. So in an instant, when you're looking at Kaplan Meier curves, you should get the impression that, man, if the event is bad, in this case it's death, the steeper this curve, the worse it is for the patient. And in fact, that holds true, because here at 3 years, your cumulative probability of survival is somewhere between 50 and 55%, as opposed to 80% in the intervention group. So the steeper the slide, or the steeper the incline on the Kaplan Meier curve with regards to the event being death, the worse off it is for the patients, or the higher risk for the patients with regards to suffering the event of interest. Again, you're a little bit afraid of the steep slides, because you should be. A few Kaplan Meier curve concepts. And so the time to event is a clinical course duration variable for each subject. And so they have a beginning and an end. And their duration is known as serial time, describing their clinical course time. And patients enter the study at point A, and the end of your observation or their serial time either ends with an event. For survival analysis, that event is death, or it ends in being censored, meaning that we do not have their data after they were censored. And in Kaplan-Meier survival analysis, each subject is characterized by 3 variables: their serial time, the time that we were following the patients for, the status at the end of their serial time, either an event occurred or they were censored, and last but not least, their study group. Were they in the intervention group or were they in the control group? And for the construction of these curves, serial times are arranged from the shortest to the longest. And all subjects within the group begin analysis at the same point in time. Well, how does that happen? I'm going to show you in just a moment. But this serial time duration of known survival is terminated by an event. Once again, we discussed when we ran over the components of the Kaplan Meier curve that only an event terminates an interval. And censored subjects are indicated by tick marks, and censored subjects do not terminate intervals. They are only represented by tick marks on the intervals. And so we talked about serial time of patients, which differs from calendar or secular time. And so here, this is a secular time picture showing you that, hey, the trial starts here, you get some stuff organized, and you begin enrollment at a certain point, and later on at a certain point in time, you end enrollment. But you follow these patients through a period in time, and there's a point where you're going to end the data collection, and then you do all the things you need to do, close up shop, lock the doors, and go home for the day, and that ends the trial. But with regards to individual patient follow-up, that's called serial time. So we're measuring the particular time for each particular patient, and each particular patient can enter the study at different points in time. For instance, we have a patient here that started the study as soon as they started enrolling patients, and they were followed all the way to the end of data collection. And this open circle here means that they were censored, which means that at the end of the trial, at the end of the 10 years of follow-up, the patient was still alive. So they're censored. We don't know what happens to that patient or what happened to that patient a day after, 2 days after, 10 years after, 30 years after. So that's what the open circle means. Let's take another example. This patient here entered the trial not at the beginning, but sometime during enrollment, and they were followed for a short period of time until a closed circle, which essentially means an event occurred. And if that event is mortality, it's indicated by the end of an interval. In fact, any event occurring, it ends an interval. So in this case, this patient was followed for this period in time. So this is this patient's serial time. This is this patient's serial time. And you can see open circles mean, hey, you know what? They didn't suffer an event, and we no longer have this patient's information. So what's done to compare the different serial times is, if we were to think of these as arrows, which they are, the head of the arrow and the feathers of the arrow, we would align all the feathers of the arrow up from shortest to longest, and that would look something like this. And when statistical computations or programs or software are constructing the Kaplan Meier curve for us, this is what the programs are essentially doing. And so we had the patient with the shortest period of serial time. You start here, and you go, and this is an interval, until there's an event. And recall, events end intervals. So since this event entered this interval, you go down to the next interval and go across until an event occurs. That ends the interval. You go down all the way to an event occurs. Now we go down. Why do we skip this one? Because remember, this patient here is going to ultimately become a tick mark because they're censored. So we drop to this interval, and you go all the way across in this interval. And within this interval, This open circle here is represented as a tick mark on the Kaplan Meier curve. So we're going all the way across, you end the interval and you drop down. Actually, you drop down to the last interval and you go all the way across. Right here, there's a tick, and all the way, if this is the last patient, there's another tick mark at the end of the patient follow-up. And essentially, that's how the Kaplan Meier curves are constructed with this statistical software. Kaplan Meier curve, key points. The horizontal lines is the survival duration for a particular interval. Intervals are terminated by the occurrence of an event of interest. Remember that censored patients don't end the interval. The vertical distance between lines illustrate the change in cumulative probability as a curve advances. And remember, these vertical distance, how far that this cumulative probability is from this one, lets you know, well, what's the overall magnitude and change in their cumulative probability over a period in time. And remember, if we're thinking about these as water slides, the more shallow water slide is better for a patient, especially when the event is survival, compared to a more steep water slide. Because in this case, with a more steep survival curve, it means that a higher proportion of patients are suffering the event at any particular point in time. Conversely, fewer patients are surviving at any particular point in time compared to the intervention group. So when you're looking at these survival curves or these Kaplan Meier estimates, and for the most part the events are bad things such as morbidity or mortality, the curve that is the most shallow is the better curve for patient outcomes, and the curve that is the most steepest is the one that indicates, man, they look like they're having a little bit worse outcomes at a higher rate. Intervals and probabilities are only constructed for events. And remember, each of these intervals here represent the cumulative probability for survival at any particular point in time. And last but not least, censoring has an effect on survival rates. Remember that censoring is essentially saying that we don't know what happened to the patient data after this particular point in time. And what that's going to do is it's going to kind of broaden or widen or make less accurate our estimates because we don't have all the patient data. Now, comparing Kaplan Meier estimates. One of the main reasons why we use these Kaplan Meier curves is because we want to compare the survival data behind or between group A and group B, or the intervention group versus the control group. And not only that, you can compare multiple different estimates from multiple different patient groups. But in general, you're looking at a Kaplan Meier curve or Kaplan Meier estimates between two groups, intervention group versus control group. And it would be interesting and simple to simply look at the curves and say, hey, this looks like a steeper water slide. Those patients are doing worse off. Therefore, whoever's in this intervention group has done better. But it's not that easy. And so we can't simply look at a series of time points. So analysis techniques must consider the entire curve. So we're comparing the overall survival curves between the intervention group and the control group. Not at a particular point, at a particular point in time, but we're comparing the entire curves. Is this survival curve statistically significantly different from that survival curve? And the differences between curves must be quantified. Remember, these Kaplan Meier curves are Kaplan Meier estimates. They're estimates of patient survival at any particular point in time. And if these estimates greatly overlap, well, then we can't necessarily say with a large amount of confidence that these curves are in fact different. So we have to quantify the difference between these Kaplan Meier estimates. And this quantification is done in several ways. But for the most part in the medical literature, you're going to see a few types of quantification techniques. And one of those techniques is called the log rank test. It's a statistical test that basically asks a question, well, is there a difference between the two groups? More specifically, is there a statistically significant difference between the two groups? And the other test that you're going to see is something called the hazard ratio, which comes from the Cox proportional hazards model. And this hazard ratio provides a relative event rate between the two groups. And so log rank test, is there a difference in hazard ratio? Well, what is this difference? How do I quantify the relative event rates between these two groups? hazard ratio. And so what is a hazard? And so a hazard is the risk of event at any particular point in time. The risk of event at any particular point in time. And if that event happens to be death or mortality, it's the risk of death at any particular point in time along the duration for which the patients were followed up in the study. And the probability of events occurring at any particular point in time in each group is referred to as the hazard for that group. So for instance, you may hear something like the treatment group hazard simply means the risk of an event at any particular time for the treatment group. And the control group hazard means the risk of an event at any particular time for the control group. And the weighted relative risk during the entire study duration is known as the hazard ratio. In other words, a hazard ratio is a ratio of hazards. And so it's the ratio of the hazard in the treatment group, which is the instantaneous risk of event in the treatment group, over the hazard in the control group, which is an instantaneous risk of the event in the control group. It is a ratio of hazards. And so now that we have this concept in mind, how do we interpret hazard ratios? And so there's going to be three options. Either the hazard ratio is going to be greater than 1, it's going to be less than 1, or it's going to be equal to 1. And so for hazard ratios less than 1, the treatment reduces the risk of event. Because if the hazard in the treatment group is smaller than the hazard in the control group, and we're taking a ratio here, that's going to be less than 1. So it reduces the risk of event. But what if the hazard ratio is more than 1? That means that the treatment increases the risk of event. And last but not least, if the hazard ratio is equal to 1, the treatment has no impact or influence on the risk of event. For the most part, if a hazard or event is equated to something bad happening, the hazard you're looking for, the optimal hazard, is a hazard ratio less than 1, because you would hope that the treatment decreases the risk of a bad event. And if that is the case, if it decreases the risk of a bad event, the hazard or the instantaneous risk in the event in the treatment group is going to be smaller than the hazard or the instantaneous risk of event in the control group. And so that's what investigators are hoping to see with these studies, where the intervention is thought to decrease the risk of a bad event. Because if they got a hazard ratio of more than 1, that would suggest that, man, this treatment we thought was going to work actually increased the risk of event compared to the control group, which would be bad. And if the hazard ratio, again, was 1, there's really no impact of this intervention. The hazard rate for any group may not be constant through follow-up. And what does this mean? Initially, you could have a high hazard, which means a high risk of mortality at any particular point in time. Say, for instance, from year 1 to 3, there was a relatively high hazard or a steep part of that curve. But then from year 3 to 10, the hazard was relatively low, meaning that that curve shallowed out. So the hazard rate doesn't have to be constant. However, it's assumed that the ratio of hazard rates between treatment and control group is constant across the study period and is approximately the same for each time interval, which is why we can take the ratio of these hazards to be our estimates of the effect of a treatment in the hazard group, or the impact of this treatment on these hazard ratios. And so, hence, the hazard ratio represents the risk of event in the treatment group compared to control group at any particular point in time during the study period. Again, the hazard ratio represents the risk of event in the control group compared to the risk of event in the treatment group compared to the risk of the event in the control group during any particular time in the study. So the instantaneous risk of event. Okay, let's do an example where we're going to quantify the difference between these two curves. Again, we had our patients with pancreatic cancer. The intervention was drug A, the control was drug B. The outcome was death. In this case, the event is mortality or death, and in those cases, the steeper the curve, the more risk of morbidity and mortality, as you know when you're going down these super steep slides at the water park. And what if you got that the hazard ratio in group A was 0.2 as a proportion or 20 as a percent? Well, what does that mean? That means the instantaneous risk of death in group A at any particular point in time during the study period is 0.2 or 20%. The hazard in group B is 0.6 as a proportion or 60 as a percent. This just means that at any particular point in time during the study, the instantaneous risk of death in the control group is 60%. And a hazard ratio is just that, a ratio of hazards. And so we got 0.2 over 0.6, which gives us 0.33. And what does that mean? How do we put that into English? So at any time during follow-up, patients taking drug A were 0.33 times as likely to die, or they had a 33% proportional risk of death compared to patients in group B. Put another way, if you don't want to look at it that way, you could look at the opposite way, right? You can say that patients taking drug A had a 67% lower risk of death at any time during follow-up. So these two statements here are essentially saying the same thing. Either the treatment group, the intervention group, had a 33% proportional risk of death, or you can also say they had a 67% lower risk of death at any particular time during study follow-up. Got it. We got the hazard ratios. But what if you were given a hazard ratio of 0.33, 60% lower risk, or 0.33 times the risk compared to the control group? But what if the 95% confidence interval went from 0.03 to 1.13? Now, as a refresher, you remember the confidence interval is that interval for which our data is also consistent with. If you need a refresher, please see our tutorial on inferential statistics, in particular, looking at the construction of the 95% confidence interval. And you may see that in the link below. But for all intents and purposes right now, you recall that if this confidence interval for ratios or hazard ratios includes 1, that also means that our data are also consistent with no effect of treatment at all. So you would conclude from this that, man, you know what, even if 0.33 looks like a good hazard ratio in favor of the intervention, our data is also consistent with no benefit at all. So we could not conclude from this point estimate in this 95% confidence interval, we cannot conclude that the new drug in this case was more effective than the old drug. However, what if you were given this? What if you were given a hazard ratio of 0.33 with a 95% confidence interval of 28% to 38%? Okay, so you now know that our data are also consistent with a hazard ratio as low as 28% and as high as 38%. This range does not include 1, which means that this is statistically significant with regards to quantifying the difference between these two groups. And so if your hazard ratio or the 95% interval includes 1, you can't say there's a statistically significant difference between these two groups, but if it excludes 1, you can state that there in fact is a statistically significant difference between the groups. Okay, now that you learned some skills, let's put those skills to work. Let's do some practical application exercises. And so in this study in the New England Journal of Medicine, looked at the long-term outcomes of patient foramen ovale closure or medical therapy after stroke. And so to give you a brief background, so a patent foramen ovale is essentially a hole between the atria and the heart, the two small chambers in the heart. In the thought process is that if a patient has a blood clot that gets in this little hole and goes from the right side of the heart to the left side of the heart, that blood clot can go all the way up to the central nervous system and get clogged in some type of artery in the brain and cause a stroke, in particular an ischemic stroke. And so in this study, they did a multi-center randomized trial, and they looked at the differences in either recurrent stroke or death in those patients who had a cryptogenic stroke, which essentially means, hey, you had a stroke and we don't know why, and a PFO, or a patent foramen ovale. And so they had these patients who had a stroke from unknown cause, but they also had a PFO, patent foramen ovale. And if the thought process is, hey, if you still have this hole in your heart, there's a potential for blood clots to get to the left side of the heart and go up to your brain and cause a stroke. Well, what would happen if we were to treat this with closing this PFO as opposed to receiving medical therapy? So the intervention group in this case is closure of the PFO, and the control group is still an active control, and they received medical therapy alone. And the primary endpoint was a composite of recurrent non-fatal ischemic stroke, fatal ischemic stroke, or early death after randomization. Essentially, do you have a stroke or do you die was the ultimate outcome. And let's take a look at what these authors did. And so here, this is one of the tables or one of the figures in this study. And so if you look here on their Kaplan Meier curve, here on the y-axis, the probability of freedom from events. In this case, the events were the composite of do you either have a stroke or did you die? And on the x-axis, years to event. But if you look at this initial graph with these metrics, they both look relatively shallow until like around here. And why is that? Because all of the events occurred in between these intervals right here. So what the authors did is essentially, in this inset, blew up the graph and expanded between roughly 86% freedom from the events to 100%. And that's what these hash marks mean here. And so from 0.86 to below, it was tremendously compressed, and it's going to allow us to get a better visual of the differences between these two curves here. And so if you're looking at these Kaplan Meier curves, the PFO closure group versus the medical therapy group, and thinking, man, what slide would I want to be on if I wanted to decrease my event of a bad outcome? Probably the blue slide here, and that's the intervention group. And the next question is, well, is there a statistically significant difference between these two groups with regards to either stroke or death? And remember, the log rank test answers that. It answers, well, is there a statistically significant difference between these two groups? And recall from our tutorial on p-values, typically in medicine, a p-value of less than 0.05 is considered statistically significant. So let's take a look here. 0.046. Whee! That's like right on the edge, but it's kind of still less than 0.05. So in this case, you can make the argument that yes, there is a statistically significant difference between the groups. And if you want to look at the hazard ratio or the risk of the event in the intervention group compared to the risk of event in the control group, is there a difference at any particular point in time? And their hazard ratio here is 0.55, or the PFO group has a 55% proportional reduction or a proportional risk of event compared to the medical therapy group. Put another way, they have a 45% reduced risk of non-fatal ischemic stroke, fatal ischemic stroke, or early death compared to the medical therapy group. So they have a 45% reduction in risk of the outcome compared to the medical therapy group. And you may look at this 95% confidence interval and say, hey, 0.999, woo, that's knocking on number one's door. So it's very close to not significant at all. I hear you, and I got it. What about for recurrent ischemic strokes of undetermined cause? So this outcome is, hey, the initial patients where you had a cryptogenic stroke, a stroke for which we don't know what caused it, but you also had a PFO, what's the risk of having another stroke that we don't really know what caused it? And let's take a look to see what happened. You take a look at these two groups and your instantaneous look at these on your general impression is, hey, the PFO group looks like they did better than the medical therapy group. Why is that? Because this medical therapy group, their water slide is much steeper than the PFO group, but you want to quantify the difference. So let's take a look at, is there a statistically significant difference between these two groups? Let's look at the log rank test. It shows us that the p-value is 0.007. That's a lot lower than 0.05. And what this means in English is that the probability of seeing a difference in magnitude of this size or larger by chance alone is 7 in 1,000. Wow. So that's not very likely. And so we would have to accept the alternative hypothesis that there's something else aside from chance causing this difference. And in this case, since they did a study on PFO versus medical therapy, we'd have to concede and say that, okay, maybe it was the PFO that caused this decrease in recurrent stroke. And if we take a look at the hazard ratio, it's 0.38 as a proportion or 38 as a percent, which basically means that the PFO closure group has 38% the proportional risk of recurrent stroke compared to the medical therapy group. And if you don't like that approach, you could say, okay, what's 100 minus 38? We'll go 40. Okay, so maybe they decreased the risk of recurrent ischemic stroke by 62%. However you like to look at it, they have a 38% proportional risk of recurrent ischemic stroke of undetermined cause, or they have a decrease in risk by 62%. So they have decreased the risk of recurrent stroke by 62% at any particular point in time during the study period. And so they can also put these in a table format. You see here, you see the same hazard ratios, and here they just looked at the hazard ratios looking at different ways to evaluate. So you have your hazard ratio and your p-value. So you can actually put the hazard ratios and p-values in the figure, or you could put it in a table. And the authors ultimately concluded, among adults who had a cryptogenic ischemic stroke, closure of a PFO was associated with a lower rate of recurrent ischemic strokes than medical therapy alone during extended follow-up. Let's do one more example. And this is the overall survival with durvalumab after chemotherapy in stage 3 non-small cell lung carcinoma. And so, what in the world is durvalumab? Essentially, that's a monoclonal antibody. And so background. In an earlier analysis, they showed that this monoclonal antibody significantly prolonged progression-free survival compared with placebo in patients with this type of cancer who got chemotherapy and radiation. And in this case, their outcome was progression-free survival. So in this case, the event was the progression of disease. So instead of death, it's progression of disease in their earlier study. But now in this study, they want to take a look and report the results for the second primary endpoint, which was overall survival. And if the event is overall survival, or if the outcome is overall survival, the event is mortality. So before, it's been shown that this monoclonal antibody has held off the progression of disease. Now they want to see, well, does this decrease mortality? And the interesting thing about these monoclonal antibodies is that it allows healthcare providers and researchers to specifically target cancer cells. So they can design a monoclonal antibody to find out and seek a cancer cell, which would allow the patient's own immune system to attack the cancer cell. But there's also ways to where these scientists in these amazing individuals in healthcare can also attach either radioactive material to these monoclonal antibodies or even chemotherapy to these monoclonal antibodies. So you can specifically target cancer cells and put some toxins on these monoclonal antibodies to kill the cancer. And so let's take a look here. On the y-axis, the probability of overall survival, and on the x-axis here, it's months since randomization. So 12 months, 1 year, 24 months, 2 years. And looking at these water slides, you would probably not want to be on the more steep water slide, which is placebo. And so they looked at the hazard ratio for death in the monoclonal antibody group versus the placebo group. And it shows you here that in the durvalumab group, they had a 68% proportional risk of death compared to placebo. Put another way, they had a 32% reduction in death compared to the placebo group. And if you take a look at their 99.73% confidence interval, which is much more than a 95% confidence interval, that confidence interval does not include 1, because remember, if it did include 1, the data would also be consistent with no effect on the durvalumab at all. And when they did something similar or exactly like the log rank test to answer the question, well, is there a statistically significant difference between these two groups? i.e., is the p-value less than 0.05? It's 0.0025, so the answer is yes. So you would conclude by just looking at this Kaplan Meier curve here that the durvalumab group had a lower instantaneous risk of death at any particular time during the course of follow-up in this study. Here, what is the outcome? So the probability of death or distant metastasis. So in this case, it's progression-free survival. So either you die or the disease progresses. So that's the event that they're looking at. And again, when you're looking at these water slides, you would probably not want to be on the steeper water slide. You want to be on the more shallow water slide because that comes with less risk of morbidity and mortality. And so let's see progression-free survival between these two groups. What is the hazard ratio? 53% with regards to progression-free survival or death. So the durvalumab group had a 53% proportional risk of probability of death or distant metastasis compared to the placebo group. Or put another way, they had a reduction in their mortality or worsening or progression of their disease by 47%. And so those are two ways to look at the same coin. And so these authors concluded that durvalumab therapy resulted in significantly lower overall survival than placebo. No new safety signals were identified. And so think about those curves on what you would interpret and think about that in relation to what the conclusions the authors said. All right. Now after that, let's review the objectives because now you can describe the components of the Kaplan Meier curve. You can discuss the type of analysis that these types of curves allow, this time-to-event analysis. And last but not least, you are now able to compare Kaplan Meier estimates between groups. And that's the most important, powerful thing that we can take from reading these Kaplan Meier curves. You know what answers the question, is there a statistically significant difference between these two groups, i.e. the log rank test, which is going to punch out a p-value, and if it's less than 0.05, you're going to conclude that, hey, it looks like there is a statistically significant difference between these two groups. And you also know how to interpret the hazard ratio, which is just a ratio of hazards. And for events that are bad, hazard ratios less than 1 provide argument and benefit for the treatment working. Hazard ratios more than 1 provide an argument for, hey, the treatment look like it's not doing so well. And hazard ratios equal to 1 basically say the treatment has no impact or influence on the outcome of interest. And don't forget to look at the 95% confidence intervals when you're also looking at the data. So you'll be presented with a point estimate like the hazard ratio of 0.33, but also look at the 95% confidence interval to see if that includes 1. Because if your 95% confidence interval includes 1, your data is also consistent with no effect at all. Thank you for your time and cooperation. Once again, this is Eric McCoy, a.k.a. McCoy, a.k.a. EMAC, from the University of California, Irvine, Department of Emergency Medicine. Signing out, work smart, not hard.
Did he say time to event? What I meant by time to event was, man, the time to the damn event! Time to event analysis. Heart attack. There ain't no turning back.